Hello, thank you for the introduction and thank you very much for welcoming me to your conference. My first time in Saudi Arabia, and it's very nice to be here. So I'm going to talk about precision medicine, which people also call stratification. In other words, identifying within a population of patients one group who will do better with a certain therapeutic strategy compared to another. This has been a promise in rheumatology, not just in lupus, but in many areas of rheumatology for a long time, but it's one that's been quite difficult to realize. So I'm going to try to focus on things that are quite close to reality and to biologics that we already may have access to. In the field of lupus, I think at least for non-renal lupus, there are 3 biologics that we currently may use. We could use rituximab, which is not licensed, but I think we all have experience of it in renal and non-renal lupus. And we could use belimumab. Both of these drugs target B cells. Then, on the other hand, we have a new biologic licensed in the last few years, anifrolumab. It's a completely different mechanism of action. It targets interferon, which is innate immunity. So it may seem that these are very different mechanisms of action, and therefore it should be quite easy to develop tests to tell us which patient is most appropriate for them. You may think that we could use a B cell blood test of some kind, perhaps an autoantibody for the B cell drug, and the interferon signature, which is a blood test for interferon activity, for anifrolumab. Well, unfortunately, I don't think it's quite so simple. So we all know the data for belimumab, I think, because this is quite old, this paper. So this paper shows the original analysis of the belimumab studies on the left here, that patients who have high disease activity, who have positive double-stranded DNA or low levels of complement C3 or C4 would be better responders, and these are B-cell biomarkers, so it seems to make sense. But then when we turn to anifrolumab, where we have a similar analysis on the right, actually down at the bottom, what you see here is that patients who have positive serological markers respond better to anifrolumab as well. And in fact, so the patients who have positive antibodies and low complement are going to be better responders, whether you're targeting B cells or whether you're targeting type 1 interferon. So it may not actually be the case that these biomarkers necessarily tell you about the mechanism of the drug. They might tell you about patients who are going to respond well in general. And when I was writing the paper for that anifrolumab analysis, I came to the conclusion that there were 3 different ways that biomarkers were stratifying lupus trials. The first, I'm sorry, the writing has come a little bit small here, but the first is that biomarkers tell us who has got active disease. Unfortunately, there are still some patients who enter into the lupus trials or who receive biologics in the clinic who actually don't turn out to have such active disease as some other patients. So if you imagine 2 patients who both come with pain in the joints with arthralgia, one of them is biomarker positive, say high antibody levels or low complement, the other one is biomarker negative. Which one will have the most active disease? Obviously, you would be more likely to see more synovitis, especially on imaging, in the ones who are biomarker positive, and that patient will respond better to any therapy. Second, in trials, it can predict flares and remissions. Even if both patients have the same amount of synovitis, the one who is biomarker positive will get more flares. We know this well. Patients who are biomarker negative will be more likely to have a response to placebo, for example, in the clinical trial. And then, after both of those things are true, after we understand both of those things, then maybe we can think about what we call an immune endotype. And that's what everyone is looking for. An immune endotype means if you have 2 patients who both have the same level of disease activity, both have the same level of flares, clinically there's no difference, is there a different mechanism underneath that's driving one disease and the other that means one drug will be effective and one drug will not? And I think all of these have effects when we try to stratify biologics. So I think my conclusion from looking at a lot of these studies is that we have to be quite careful that simply doing a blood test is probably not going to contain all of the answers. When we look at lupus trials, there can be very important effects from the demographics of the patients. Their ancestry, their ethnicity, socioeconomic variables can influence outcomes. You have to think about which organ is affected and how active the disease is in that organ. We have to think about whether this patient's lupus is primarily driven by adaptive or innate mechanisms, or both. And actually, we also have to think not just about immune mediators in the blood, which are easy to test for, but actually the most important immune mediators may be in the tissues. Interferon being a classic example, which is more produced in tissues than in the blood. And we also have to think about the therapy background of the patients. If a patient has already failed B-cell depletion, you can already say, before you do any testing, that they're more likely to have a non-B-cell mechanism of their disease. So in the next part of the presentation, I'm going to talk about those areas. Firstly, identifying active disease with arthritis as an example, and then some B-cell and interferon biomarkers, and trying to bring these things together. So imaging, which identifies active disease, may be one of the most important biomarkers, rather than a molecular one. If you take patients who walk into the clinic with joint pain, like I did, I took 112 patients, anyone who said their joints hurt, and they all got an ultrasound on the same day. Then what you can see is that there are some patients who have swollen joints, clinical synovitis. We already know what to do. They've got active disease. We know we need to treat them. Easy. We have some patients who actually, on imaging, the ultrasound was normal. They actually don't seem to have inflammatory disease. And there are some patients who don't have swollen joints, but actually on ultrasound did have synovitis, 27% of patients, who perhaps we underestimate. And so identifying active disease like this may be important. We wanted to know if we should treat according to the ultrasound rather than according to the clinical appearance. So we did this study called USEFUL. In the USEFUL study, what we did, we took 133 patients. Similarly, they just had painful joints, and the referring physician felt that it was due to inflammation. They didn't have to have swelling. They had an ultrasound at baseline, and then they were treated with steroids, intramuscular, and then assessed over 6 weeks for a variety of clinical and patient-reported outcomes. So these are just the baseline findings. So there was disagreement between ultrasound and swelling in both directions. So if you take patients who had swollen joints, there were 66 patients, 53 of them had it confirmed on ultrasound, but 13 did not have a positive ultrasound. Of the patients who didn't have swollen joints, 67 patients, 25 of them actually did have positive ultrasound. And then in the other direction, you can look again, of the ultrasound positive patients, which is 59% of the whole cohort, quite a significant proportion of them didn't have swollen joints. So there's disagreements in both directions. How could you tell who was going to have active disease if you didn't do an ultrasound scan? Some things were obvious, some things were surprises. So the person doing the clinical assessment was blinded to the result of the scan. So the best predictors of ultrasound on clinical assessment, obviously swelling, of course. Then other things were essentially having a symmetrical small joint distribution, both associated. Also, having RMP antibodies had a trend to association, and having higher levels of IgG. Within the normal range, but high end of normal. There were, in the ineffective predictors, surprisingly, early morning stiffness did not have any association with ultrasound, even though we commonly use this clinically. Also, people who said they responded well to steroids in the past was not associated with a positive ultrasound. So then what about the primary outcome of the study, which is shown here? The primary outcome of the study was to ask whether ultrasound positive patients would show a better response to therapy than ultrasound negative. So if you look on these error bar charts, if the bar is, this dotted line means no effect. If the bar is to the right, it means the ultrasound negative responded better. If the bar is to the left, it means the ultrasound positive responded better. So in our primary analysis, we saw a trend to a better response in ultrasound positive patients. But we also thought, when we planned the study, that some patients also have other conditions, like fibromyalgia. So we had a secondary analysis where we excluded patients who had fibromyalgia. And then when you exclude patients with fibromyalgia, you can see that ultrasound positive patients clearly responded better than ultrasound negative. Also confirmed here BILAG and SLEDAI scores for improvement. Okay, so we need to identify what is active accurately, first of all. Then let's think about the mechanisms. First, B cells. So B cell depletion has offered some important lessons. When we give rituximab for lupus, we deplete B cells, but not all B cells, and that's the most important thing about rituximab's effect. B cells start as stem cells in the bone marrow. They come out into the periphery as mature naive B cells. And then if they don't see their antigen, nothing else happens. If they meet their antigen, for example, double-stranded DNA, then they become activated. They can migrate into lymph nodes and have T cell help. And then they differentiate into memory B cells and plasmablasts. Plasmablasts only live for a few days in the blood. They're looking for a niche in the bone marrow where they can turn into a plasma cell where they can make antibodies for years. If they do find that niche, they'll do it. If they don't find that niche, they die. When we give rituximab, we target CD20, which only targets this population, which means that the stem cells are always there, the B cells can always come back, and the plasma cells are always there. So your long-term immunity is not impaired. But what we often see, plasmablasts don't have CD20. So we often see them on their own in the blood after rituximab, but they only live for a few days. So if you're seeing these in the blood, there must be some B cell activity going on somewhere else. And that's what you see. This is what it looks like when you look at B cell depletion. This is flow cytometry. Here's the naive B cells in green before treatment. Here's the memory B cells. Here's the plasmablasts in purple. After rituximab, what we often see is plasmablasts on their own without any naive and memory B cells, indicating ongoing active B cells differentiating actively. When patients have persistent as incomplete depletion, you see that they fail to reduce antibody titers and they fail to get a clinical response. So now we know why this depletion does vary between patients. Actually, it's genetically determined. When B cells, when we use rituximab to kill a B cell or a tumor cell, as shown here, the rituximab binds to the surface of the cell, but that doesn't actually make the cell die. For the B cell or the tumor cell to die, you also need an effector cell, such as a monocyte or an NK cell, which has an Fc gamma receptor. Fc gamma receptors detect monoclonal antibodies, and that does the cell killing. These Fc gamma receptors have a lot of genetic polymorphisms, and some have higher affinity than others. And what we found is that the higher affinity variant with the V allele was associated with more complete depletion and better clinical response. So the efficacy of B cell depletion depends on how well Fc gamma receptors bind. And I'll tell you in my other talk this morning about what that means in terms of therapy. But before we do that, what about interferon pathway activation? So now that we have drugs that target interferon, do we need to be able to measure it in the clinic? Type 1 interferon means interferon alpha, beta, epsilon, kappa, omega. All these different interferons all bind to the same receptor. That's why we put them together as a group. All type 1 interferons bind to this type 1 interferon receptor. Then you get a JAK-STAT signaling pathway, and you get expression of what we call interferon-stimulated genes, which have antiviral effects and also cause an immunostimulatory response. Measuring this is more difficult than you first think. Simply measuring the level of interferon alpha in the serum is very unreliable. With standard assays that we use in routine immunology labs, you won't detect any interferon at all. There are some specialized assays called Simoa that can detect the interferon in the serum, but the levels are very, very low. So low that they're too low to influence the cell. And the reason is that a lot of the interferon activity is not occurring in the blood. So when we want to measure interferon activity, instead of using these kind of immunoassays, what we actually have to do is measure what happens downstream of the interferon receptor. And the main methods used are gene expression assays. So we look at the expression of these genes, which is stimulated by type 1 interferon, and the mRNA level, and we can generate something called an interferon signature or an interferon score that tells us the activity. These interferon signatures seem to be very useful in lupus studies in predicting various clinical features. For example, here, can we make a diagnosis? So red is SLE, blue is rheumatoid, and white is healthy controls. And you see that the interferon signature is very clearly associated with SLE compared to rheumatoid or healthy. You can use it to predict flares. So if we take SLE patients and measure interferon signature, those who are interferon signature high are much more, those who have a flare after the test are more likely to have a higher interferon level. And you can also use it to predict response to therapy. I already showed you for anifrolumab that interferon signature could predict response to anifrolumab. That's also true. These data are for rituximab. So just to finalize, when you think about these immune biomarkers to identify patients who will respond well or less well to certain classes of therapy, what many of us started to think is that, does this mean that we should stop using traditional diagnosis? Interferon signature is high in about 75% of lupus patients, but it's also high in some Sjögren's patients, and it's also high in some patients who have myositis and scleroderma and mixed connective tissue disease. So if I want to block interferon with my therapy, maybe I should just take all the interferon high patients from all these diagnoses and just put them together and forget what the diagnosis was. Maybe if I've got a drug that targets complement, I should take patients who have Sjögren's with low complement and lupus with low complement, for example. And so this is something we're exploring at the moment. So you can see this concept already with things that we already do in the clinic now, even without doing any sophisticated testing or research. If you think about some of the most common and oldest well-established biologics that we use, we have TNF blockade, B-cell depletion, and IL-6 blockade. We all use them every day, but these drugs have forced a kind of reclassification that you never would have thought about in the 1990s or in the 1980s, because rheumatoid arthritis, for example, can be split into seropositive rheumatoid that we might treat with B-cell depletion, whereas seropositive and seronegative can be treated, say, with anti-TNF, and that means that seropositive rheumatoid is now grouping together with ANA-associated diseases, ANCA-associated vasculitis, even IgG4. So you get groupings that only make sense in terms of the therapies we use, not in terms of the clinical syndrome of the disease. And so when you think about the ANA spectrum of diseases, these diseases overlap a lot. Patients, if you take all the ANA positive people in the clinic, you have a cluster of different symptoms: arthritis, vascular features, hematologic, cutaneous features. And certain combinations of these, we call them diagnoses, like lupus. But these diagnoses may overlap. Some lupus patients may also meet criteria for Sjögren's, and many patients won't meet any of the criteria. So when we take patients and take one disease, like lupus, and then go through trials of B-cell therapies, interferon therapies, others, a lot of these trials fail. And in a lot of these trials, one subgroup is responding better and one subgroup is responding worse. So it may make more sense to take patients, no matter how they appear, individual patient profiles, organize them by their blood tests, and then do trials of basket populations, as we call them. And we're trying to do this in my lab at the moment using two large cohorts. One European cohort called Precise SADS, 1,200 patients, another one called Definition, where we take clinical features and molecular features and perform a machine learning-based reclassification and form new groupings of patients. And this is our preliminary results, that when you take the initial diagnoses, myositis, Sjögren's, lupus, undiff, scleroderma mixed, and we reclassify them in different ways, we end up with new groupings, which could be like SICA, or could be like musculoskeletal, or they could be based on an immune test, like this myeloinflammatory group or plasmablast group, but each of those groups is based on many different diseases. So just to summarize, I think the existing stratification, high SLEDAI and serological activity are good biomarkers for treatable disease, but might not tell you a certain type of therapy. Imaging is very useful to tell you definite active disease. In B-cell therapies, the depth of depletion and the pattern of repopulation is really crucial, and this depends on Fc gamma receptor affinity. Interferon signature probably has many roles in the clinic, not just in choosing therapies. And in future, I think we may look at new classes of therapies that define new types of trials and therapeutic targets. So thanks for your attention, and I'm happy to take any questions.